Hi everyone. Hello everyone. Dr. Amin here. We're a little bit earlier than the time we talked, but it's because Dr. Tara doesn't have her time is very limited, so we start earlier than scheduled time. Hi everyone, good to see you all. Beautiful Friday, sunny Friday here in Toronto. Let me know where you're from. Hi everyone, good to see you all. Dr. Tara is here. I'm going to invite her now. Hi everyone. So you can type. Oh, hi.
Hi, how are you?
Hi, Dr. Tara. How are you?
Good to see you, and
Good to meet you.
thank you for pronouncing my name correctly. It's Tara, not Tara, but everyone says Tara, so I appreciate that.
Good to see you here. Thanks for coming to live today. So before we jumping into questions, I thought it's a good opportunity to introduce ourselves. Some of the viewers are new here. I'm Dr. Amin, Bahar Amin, a GP, traditionally trained GP from the UK. For the last 11, 12 years, I'm practicing in Canada, Toronto. Uh, Family practice still a little bit, but now my focus, my passion is in functional medicine. I just love it. Last 5 years, board certification in functional medicine, and it's just mind blowing. It's amazing, especially with the prevention, and it just gives me the opportunity to empower my patients and let them be the CEO of their own whole health. So that's so important. And prevention is the prescribing antacids, antidepressants, and anti-obesity medications. We try to get to the root cause of the problem. So you tell me about yourself, Dr. Tara.
I
How
am,
did you start
yeah,
the journey of functional medicine?
I am just across the pond, a short 45-minute flight on the other side of Lake Erie from you. Yes. And I'm a traditionally trained OBGYN. So I spent many years delivering babies, doing surgery. And through my own struggle with infertility, I had to take medications to get pregnant. And then after I wasn't trying to get pregnant, I was still left with the same hormone imbalance. And actually, a pharmacist friend of mine invited me to go to a course 20 years ago, way
Wow.
before there was all the evidence we have in the studies, and right around the time of the WHI. So I went to a course, and it really opened my eyes about root cause medicine and getting to the root of everything instead of just treating protocols, really measuring levels. And so I am still in touch with that pharmacist today. We teach a course together. And so that led me to become first a certified menopause practitioner, which is more traditional, to get a little bit more information about menopause, which we do not get as an
Mhm.
OBGYN. And then after that, I went on to do the fellowship for A4M, and then also got my board certification in integrative medicine. So there's so much more available for teaching now. And for, I'm fortunate I've been able to teach people as well through A4M and other NLP3. And there's more with the internet,
Yeah.
social media, online courses. So it was harder 20 years ago to find information and that kind of thing in
I
courses.
know.
So I'm always excited when somebody is excited about me, about prevention and getting their patients healthy. So
I know, it's great. So that's lovely. Let's jump in and dive in. So so very important is about the changes. So people asking what are the changes women going through menopause transition, what they should expect. This is a questions always when they have to expect those changes, those subtle changes sometimes. So it's a very general question, a wide question, but I think it's important to know.
yeah, Well, the average age in the US of menopause is 52, and menopause is 1 year without a period. Prior to that, the definition of perimenopause is once your normal cycle lengthens or changes by 1 week. So if you have a 28-day cycle and then you have a 35-day cycle, by that definition, you're in perimenopause, which means you could really be in perimenopause for years. So back that up, 42, late 30s. I mean, I started late 30s in perimenopause. And what it actually ends up happening is, if you were to go to your OB and say you wanted to get pregnant at 40, they would say, well, you're advanced maternal age because you have an increased risk of chromosomal problems with your baby because your eggs are old. But then once you're not trying to get pregnant, no one's concerned about what do those old eggs mean. Those old eggs don't produce as much estrogen, and they certainly don't produce as much progesterone. And because they're old, they don't respond to the brain signal to ovulate. So that increases. And so you actually get more estrogen first in the 40s, less progesterone. The most common symptoms people present with are, heavy bleeding, weight gain, poor sleep, and new onset anxiety or depression. That's the biggest one. Mood changes. Sometimes it's breast tenderness, and like I said, it might be weight gain, bloating, heavy periods, but more often it's not necessarily the bleeding they're complaining of. It's the weight, sometimes low libido, fatigue, energy, mood changes. And those for me started in my late 30s.
Wow, that early.
Mm-hmm.
Yeah.
Of course, it determines a lot. It depends on a lot. It depends on what you eat, what your stress level is, movement, and also your genetics.
Exactly. So that brings us to the next question. So as a functional doctor, so you want to be holistic and a lot of natural ways of dealing with issues rather than medications. So it's about how during this period of time, what to do these women, how to deal with the issues and naturally optimize the hormone levels before getting to HRT and treatment. What they should do about the general lifestyle. What would you recommend to your patient?
Sure. Well, everyone goes through menopause. It's inevitable. 100% of women go through it. So there's no stopping it or delaying it or preventing it, right? So I kind of have like 4 pillars of what people need to do. First, food is so important, what you eat. And it's the same for really any approach that anybody with functional medicine would do. We'd say, a naked diet. What does that mean? That just means food in its original form. That doesn't mean you have to sit and eat naked, obviously. It just means that you're not eating a lot of processed food. So for hormones, it's best if you cut out the processed food, minimize the alcohol. Some people would say alcohol. Some people say minimize. I mean, on the weekend, a drink or two, I think is fine. It's the women that are cooking and stressed and having a drink of wine every night that could do that. So
Yeah.
less alcohol, less processed sugar. And then whatever diet you like, whether it's vegan, whether it's paleo, whether it's, whatever, high protein, most women in their 40s start to get carb sensitive. So pay attention to the type of carbs. A lot of women don't eat enough protein. So we have them eat at least an eighth or 1 milligram per kilogram of body weight for protein. So cleaning up your diet, eating cruciferous vegetables, broccoli, kale, cabbage, blueberries, those are good foods. Fatty fishes, those are good foods as well. And then the foods that are good for your gut, like sauerkraut. So diet's very important. Movement, very important. Now, you don't have to go run a marathon, but a lot of us, especially with virtual visits now, are more sedentary. When I was doing OBGYN, I was seeing 40 patients a day and I was running in the office, patient, patient, patient. Now I sit and I see a patient every 45 minutes to 60 minutes. And maybe, some of them are, almost all of mine were virtual yesterday. So it's like, then you're sitting, right?
Yeah.
So my job was not sedentary before. It is more sedentary now. So I try to move almost every day. I have one rest day, and it could just be walking. Today I run with my friends. I usually do a long run on the weekends, but movement is so important for you. So what social exercise is better than, I think, because then you have an accountability, and women start to lose muscle. So weight training, even though I hated it before, I really, after my 40s, have really, and especially after my 50s now, have really tried to incorporate weight training for bone health and osteoporosis prevention and muscle wasting. So movement, very important. The third thing is sleep. I mean, some of my patients think, oh, I only need 5 hours of sleep, 6 hours of sleep. The body needs 7 to 8 hours of sleep, just natural, to restore. So if you're not giving yourself enough sleep, that's the problem. Well, maybe you're giving yourself enough sleep, but you're not sleeping. Then we have to figure out what that's from. And the last thing is stress. We don't have any control over our stress. So it's not reducing your stress. It's how does the stress affect you? So you have to have your tool, whatever it is, whether it's meditation, yoga, heart math, breath work, needlepoint, knitting, sitting with your pet, listening to music. It's got to be something, and only you know what's going to be. But if you can reduce your stress, great. But many of us cannot control our stress. So you've got to figure out how does your body manifest and how does your body adjust to it, and what can you do? What tools can you do consistently to modulate stress?
Very good. That's your 4 pillars.
That's my
That's
those are the natural things. And then of course there's symptom relief that could be, depending on what it is, we could do something and all of those things before we talk about hormones.
Yes. And some of those, like cruciferous vegetables, are great for detoxification, gut and liver, which is great and foundation of the whole thing, which I love to do for the patients. So another interesting question is we talk about hormones, estrogen, progesterone, testosterone. They're so important for one's health. Some cases, prevention of some very serious disease. Now, the question is, if one doesn't have symptoms of menopause, which mainly is hot flashes, one of them, they're questioning, should they go and start hormone replacement therapy or just wait? So that's a question, interesting one. What do you normally do with the patients who are not having much or none symptoms?
Well, that's a great question. And so according to the FDA, the reasons to give hormone therapy are hot flashes or night sweats, prevention of bone health, which applies to everyone, right? Genitourinary symptoms of menopause, which can be painful sex, painful urination, frequent urination, getting up at night to pee. So it doesn't have to be necessarily painful sex. And the fourth thing is if you have premature menopause prior to the age of 45. So those are the indications. And if you don't have hot flashes and you don't have any symptoms, should you take hormones? So we do know that there is some bone protection, and the bone loss is the greatest the first 3 years after menopause. So that is an indication. If you have a family history of osteoporosis, or if you're a thin patient, or if you have a thyroid problem, if you have any risk factors for osteoporosis, because the death rate 2 years after a hip fracture is higher than 10 years after breast cancer. So it's a significant disease burden. So if that's not an issue for you, then what about the mood issues? So midlife mood changes, especially if you have an issue with postpartum depression. So the mood, even though we don't say it's an indication, there have been studies that say it can be useful for depression midlife. I personally think my mood is completely different with hormones versus non-hormones. Have never been depressed, but when I started dropping my estrogen, I felt depressed, and I went to a therapist and thought, do I need an antidepressant? But once I started taking the estrogen, it's really amazing how my mood personally had really changes. So the quality of life symptoms are going to be different, whether it's weight gain. We know that your metabolic rate goes down and you gain weight in your abdomen. That's not really a reason to take it, but there can be something that can be improved. We see a 19% reduction in diabetes. So if you have a problem with the glycemic, we see a jump in cholesterol. Again, those can be benefits of taking it. We have just the skin, hair, and nails. I mean, the texture completely changes with estrogen. It could be hair loss, or it could just be breaking off, or just dry hair, dry skin. Those are things that can be symptoms of low estrogen. Cognitive couple studies coming out that are showing about the relationship between estrogen and Alzheimer's. Again, not an indication, but some of patients want that brain protection. There was an observational study over 400 people that showed almost a 60% reduction in Alzheimer's in patients that took hormone therapy. And the ones who took a bioidentical form had a higher, and those were women 65 who had taken it for 5 or 6 years, so older women. So the heart protection also with the cholesterol and the glycemic control, we do see that there is some heart protection when you start it at around the time of menopause. And then just the other symptoms, better sleep, better moods, better energy. And again, sometimes people say they don't have hot flashes, but they do have those other things. Libido. Of all the things that have been studied, and there haven't been a lot of things for women because there haven't been those studies done, estrogen is the one that seems to help the most for libido. Testosterone has been shown possibly to help, but it's really estrogen that has the most data behind it because it's been the most studied.
Yes, very true. Great. So, yes, yes. But then the question comes that what about, I have many patients still in the day and age, they say, but doctor, I had a family member who had a breast cancer due to that Women's Health Initiative study many years ago. Still people are scared. There's a fear of that estrogen or hormone treatment, and what if I have a breast cancer? So what do you answer to those patients?
Yeah, I mean, that's the problem is that study was 20 years ago. And the point of the study was not to see if there was any risk to the medication. The point was to see, does it reduce heart disease? Because they wanted another indication from the FDA. And in that study, women were older, they were over 65. There were only 8,000 people that got the drug and 8,000 people that got the placebo. And they did see an increased risk of breast cancer. Now, the North American Menopause Society says that between the ages of 50 and 60, you actually have more benefits to taking hormones than risks. And the risk of breast cancer is 1 out of 1,000 for bioidentical forms, 3 out of 1,000 for the Prempro that was studied in that study. That particular hormone is not the same and does not have the risk because it was an horse estrogen and it was a synthetic progestin. And there have been many studies that have shown that the progestin component does seem to carry an increased risk of breast cancer. There was another observational study that women 40 to 64, 80,000 women, and there was no increase in breast cancer when they took the hormones for 8 years, and they took an estrogen through the skin and a bioidentical progesterone. And they compared to people who took no hormones, they had no increased risk of breast cancer. There are some observational studies, but remember, again, 80,000 versus 8,000. I mean, in the Nurses' Health Study, the same thing. So, I mean, we have other studies, but because they're not randomized placebo. Well, placebo studies are important when you're studying a drug, right? But people also get breast cancer when they're not taking hormones, right? So how is it that they're your own body? So is it your body's estrogen that's causing you? And that's what I see with a lot of breast cancer patients is they don't have great estrogen detox.
Yes.
So if you have, I don't think having a first degree relative is a reason not to take hormones if you want to. If you don't want to, great, we support you, right? I guess if it really depends on what you're comfortable with. I actually have breast cancer patients, survivors, who want to take hormone therapy because they have such bad osteoporosis or symptoms that are debilitating.
Yeah, absolutely. So again, another woman, 60 years old, whose doctor declined and denied her to have HRT. So she's asking for help. We know that according to the guidelines, you have to have HRT, or you can have it within 10 years of menopause or not before 60. So what the other women over 60, what they should do? What do you...
Well, it depends on how old they were with menopause. I have a patient now, she's 56 and she's 62. So she's within 10 years of menopause. So she could still start it over 60. And that's just to start it. That's not to continue it, right? So if you're already on it, it doesn't mean at 60 that you need to stop it. The North American Menopause Society and the American College of OBGYN has no end date where you have to stop hormone therapy. Now, in the US, we'll still get these annoying faxes from the pharmacy saying, your patient is over 65 and you're treating them with estrogen. you
Yes.
know, like it's a flag. So I just ignore them, delete, you know. So starting estrogen over 60 is tricky if it's been over 10 years since your period.
Mm-hmm.
Um, because it just depends on what the symptoms are and what the reasons are. And it would be an individual discussion with each patient, but I would discuss it with each patient and then decide, you know,
Mm-hmm.
we do. The other thing we always do is we always check after we get them on hormone therapy how they metabolize it with the dried urine test. So I think that's part of the reason we went wrong before is we weren't checking those things. We're just giving hormones and then never monitoring anything or just seeing how people actually processed estrogen.
Exactly.
That's like charging on your credit card and not paying off the balance. You're going to eventually have a finance fee. And even if you cut up that card and never use it again, you're still going to be paying on that.
So that's again one of the other questions, that should we do a test? Should we check hormone levels? Or some of the endocrinologists or OBGYNs are against it, that for women, they just, as soon as they have menopause or symptoms, go straight on hormones and that's it. For indefinite stay on hormones, or after 10 years come off without any checks. What
Yeah,
are you that?
that is the standard of care. It's not indicated to check hormone labs. I don't agree with that because I don't understand where that's coming from, right? Because we check hormone labs on a patient trying to get pregnant all the time. They vary day by day in the cycle, but we know which days to check the hormone labs. So in perimenopause, we don't need clinical labs to diagnose either perimenopause or menopause. And so that's where that's coming from. You don't need the labs to diagnose it. I
Yeah,
agree. We make the diagnosis on the history.
exactly.
However, why should we check labs? Well, there's some publications by the North American Menopause Society that's saying people with lower levels of estrogen actually have an increase of osteoporosis, or higher levels of estrogen increase in breast cancer, and studies that show that those levels were protocol for men to check hormone levels, give testosterone, and monitor. Even for transgender hormone therapy, check hormone levels, give hormones, and monitor. But for women, don't check. What about the women in menopause? I understand the argument in perimenopause, but I still think it's helpful. I still check in perimenopause to look and to make to make sense of it, because sometimes people have hot flashes and they don't have low estrogen. They have
Oh,
high estrogen and low
yeah.
progesterone. So hot flashes alone isn't pathognomonic of low estrogen. So that's why I check. Now, when you get to menopause, what do you mean women's hormones are fluctuating day by day and we can't check it? They're in menopause. They're not cycling. So why is it okay to check levels for men and not for women? I don't understand it. So I think it's just, I don't want to say that it's misogynistic and that the protocols are made for men. I'm not going to say that, and I don't want to be cliche, but I can tell you that for 20 plus years, I've been doing this in my practice and checking labs. Nobody has come to me and said, oh, and it's different in Canada, I know, but a lot of the labs in the US are covered under insurance. It's not like someone can afford traditional serum testing. So most of the time covered under insurance, unless you have a really high deductible. And I think it's very helpful. Now, do we get some levels that are totally crazy and we don't understand it? Well, yeah, of course. But you also go with the patient's symptoms, their history, their clinical presentation, plus the labs. It's not like we're only looking at the labs and not listening to the patients,
Mm-hmm.
you know?
It's all
So
about
that's,
balance.
yes, it's all about it's pieces of the puzzle. So I think it's helpful for patients. And yes, you're right. My traditional colleagues are going to be like, you know, what does she know? It's not indicated, you know, there's no research behind it. Okay.
Yeah.
You know,
I do check. I do check. I love urine tests, especially for checking on cortisol, because that could sometimes be the case of hot flashes, or insulin, checking on serum. It's very helpful. Thyroid and all other hormones. So I think we should check everything, and to have all in a picture is very important. And my dog is
agreeing. Your dog's agreeing.
so now. What about your thoughts about asking about the medications for obesity, the GLP-1 agonists? especially Ozempic for weight management, especially during this period of time. Here in Canada, because of overprescription, we are back order. We not have it anymore. So
Yeah.
there's so much. I mean, I myself have seen a very good outcome with my diabetic patients. Amazing. It works beautiful. And also seen with bariatric surgery patients who want to go lower, then Ozempic really good. Couple of patients pancreatitis, and they had to stop. They couldn't continue with all those symptoms, and a lot of them I've seen after a while stopping, they regain, unfortunately. So I'm not sure what the plan is. We don't know about the long-term complications using these medications, fairly new. What are your thoughts on them? Or generally, I mean, management of obesity or
Yeah.
weight?
I mean, we do use them in our patients that want to use them. And the unfortunate part in the US is that it's expensive, right? And so and it's not always available and not always covered unless they are a diabetic. So we have a lot of pre-diabetics that are insulin resistant, that no amount of exercise and caloric restriction is going to help them lose the weight. They're doing the work. And with our patients, the medical weight loss program that we have, they have mandatory health coach talking about their diet. So we're not just prescribing a prescription and saying, hey, have a nice life. Now think about those trials that say the patients gain weight. Who did those studies? The drug company. Do you think
Yes.
they want people to go off of their drug? No, of course not. They would want them to stay on it. And in those studies, I don't think they address diet and lifestyle. They put people on semaglutide, they took them off, and yeah, people gain the weight back. Well, if you're somebody with poor eating habits that's not exercising and you're not doing anything, I had a patient the other day, again, he's pre-diabetic and also gluten sensitive. And she said, oh, I don't think I'm going to eliminate gluten. I'm just not going to do it. Okay, well, I appreciate your honesty, but there are some people that just aren't doing what they're supposed to do. It's hard. It's hard to eat healthy. It's hard to exercise. It's hard to do all those things, right? You have
Yes.
to be a highly motivated individual and health conscious and understand the long-term payoff, because there's not always a short-term payoff,
Mm-hmm.
right? So we do use those medications with our patients when the patient's, able to have the prescription. So far, I don't think we've had people gain weight back. We're also managing their hormones. We're also talking to them about diet and lifestyle. We've had some people, one person had a bowel obstruction. Yes, some people had some extreme nausea. They couldn't tolerate it. So
Yes.
we've had some side effects with patients, but for the most part, I'm seeing cholesterol go down, insulin go down, A1C go down. So I think it's been really beneficial. I have a patient that I was working for forever in her 60s that was pre-diabetic, couldn't tolerate the metformin, just was
Mm-hmm.
terrible diarrhea, could not tolerate it. Nothing we were doing was doing anything. She decided to go on it, and she's lost, I don't know, 25 pounds again. And she feels great. Her lipids look great. Her glucose is great. And, nothing was helping.
Yes. Yes. So there are some indications using or prescribing them. Yeah, but I have like BMI of 23,
Yeah.
asking for,
Yeah.
can I have Ozempic, doctor? So it's hard to,
Yeah.
yeah, control.
We don't like to do it in that
Yeah.
case. And I know there is that happening like in Hollywood with stars trying to lose 5 or 10 pounds, and that contributes to the shortage. Most of the time our patients are pre-diabetic, maybe even diabetic.
Mhm.
So I had a patient that, it got denied. She was pre-diabetic. Her hemoglobin was A1C was 5.9. She couldn't tolerate the metformin. 3 months later, her A1C is 6.5.
Wow.
So I just tried again I actually haven't heard back. So I have to check up to see if she ever got the medication. Go like, okay, wait, now she's a diabetic. Now you're going to cover it. So,
Exactly.
but
Yeah.
she had lost some weight doing some diet and exercise. But again, she was one of those people that was like, I don't think I'm going to do that.
Yeah.
So again, we're not here to judge our patients. We're here to meet them where they are, help them however they can help themselves.
Exactly. That's true. The new medication for hot flashes, non-hormonal Visua,
Vioza.
which we
Yeah,
use,
Vioza.
which we don't have it here in Canada yet, but I have many patients asking about it.
It's
So
really expensive. I don't know what the cost will be for you in Canada. It's very expensive. I don't know what it was. It was like $500 or $800 a month
wow.
here. Um, I think for the select patients, the often the only time that the only person that cannot take hormone therapy, and I'm generalizing here, is a breast cancer, like that undergoing treatment right now, right? If you've been 5 years from your breast cancer, in my practice, there is a chance you could take hormone therapy depending on a lot of things.
Yeah.
Okay. So again, just speaking generally, so those patients, I have a patient who's in her 30s and on hormone blockers, because of recurrent breast cancer. And so for her, we are going to prescribe it, as a treatment of sleep and hot flashes. So it is non-hormonal, working through a completely different system. So I think it's an option, but why do they have to make it so expensive? You know? So.
So have you received any feedbacks, patients?
No, I haven't heard back from her if it helps or not. I mean, I did see, because I was at the NAMS annual meeting, and when I presented a poster, that poster was right across from me. So I was chatting with the doctor who did the research on the drug, and it looked pretty good. I mean, it's good to have some options, there. And if there are some people who do not want to take hormones, it's great to have an option for them.
Exactly. Someone is asking about testing, how frequent you test hormones.
So when I have patients that are going through perimenopause, a lot of times it's every 4 to 6 months. If someone's stable on stable hormones, we do check every 6 months. I mean, rarely we'll go once a year, but generally we like to check it every 6 months.
Good.
And sometimes more frequently, 3 to 6 months in someone who is going through perimenopause and changing a lot.
Yes, I agree. And can mood changes after the age of 40 be enough to start hormone therapy with estrogen?
Well, a lot of people in their 40s it's not that they need estrogen, they need progesterone. And it depends on the situation, whether that person is menopausal. But yes, mood is something that is from low progesterone. So I would probably be looking at the labs on that person and considering that.
Yes, anxiety and sleep and mood. Um, exactly. Again, someone is asking about sleep. Why is it affected during this period of time, and what we can do instead of prescribing Ambience or Zopiclone or those medications? Why is it? What's the problem with sleep?
Falling asleep usually is controlled by progesterone. And so usually a lot of the people, once they are taking progesterone, their sleep is better. Early morning awakening can be a low estrogen, and then waking up with your mind racing can be a cortisol issue. So we check the hormones and we see. If it's a cortisol issue, some great things like melatonin or L-theanine, chamomile, lemon balm, some herbs are also good. Magnesium is good for all of that. If someone doesn't want to take progesterone, they could try chasteberry. I don't know if it would really help. So I think that a lot of times our patients, once we discuss the risks and benefits, they generally don't have much objections to progesterone, and it's pretty well tolerated. Small amount of people can't tolerate it, but it's pretty well tolerated.
Exactly. Oh yeah, progesterone. I love it. Now, what about the low libido and vaginal dryness during this time? What do you normally recommend or prescribe patients during perimenopause, especially, or
Well,
menopause?
a lot of that can be from low progesterone and estrogen dominance, or it could be from low estrogen. So if they're not interested in saving or doing a systemic hormones, vaginal DHEA, in my experience, is by far the best. Now it is available, FDA approved as Intrarosa, sometimes not covered. Sometimes you need a prior authorization. Again, I don't know how things are, but if you can get it compounded, and there's lots of compounding pharmacies in Toronto,
Yeah.
I know,
Yes.
and you can get it. It's not very expensive then. That is by far the best thing. It's the thing that works on all four phases: desire, libido, climax, sensation, vaginal dryness. So it's and without a concern of increase in estrogen levels or breast cancer or systemic issues. So that's my favorite thing to do. If you're postmenopausal and have low libido, the guidelines would say you might qualify for a trial of testosterone, and it could help. But, I don't generally give testosterone if someone's not on estrogen or progesterone. I mean, I would, but I don't. I think you need to maximize the other hormones first.
Exactly. with DHA, I've seen the oral, the drops, sublingual ones are a lot of times breakouts in women, so they prefer to have either transdermally or transvaginal. So
Yeah,
yeah,
it's generally dose related, and then it depends on that 5-alpha reductase on the Dutch test if there's someone who sends it that way.
exactly. The question, any thoughts on FSH and how levels rise as we progress through perimenopause?
Well, there was some data on that at the I think it was not last year, but the year before, as far as I can't remember if it was cognition or what it was, and FSH. But remember, FSH is inversely proportional to estradiol. So when estradiol is low, FSH is going to increase. So if we're saying that correlates with cognition, it's the low estrogen that actually correlates with cognition. So yes, I find FSH helpful when we're talking about ovarian reserve and to understand where they are in the scope in perimenopause. I don't dose to suppress FSH. I know there's some people out there that use those protocols. I'm mainly looking at the estradiol levels. So I mean, something that we definitely check during perimenopause.
Do you prescribe pregnenolone ever?
Yeah, I mean, actually, in
Other
Canada, it's regulated. Here in the U.S., it's over the counter. It's like you can just go get 100 milligrams and treat yourself,
Wow.
with no doctor. Yeah, it's crazy here.
Like
And
DHEA, I think you have
yeah,
it over the counter.
DHEA, people can just put themselves on it, put themselves on 100 milligrams, but in Canada and Australia, it's regulated like a narcotic. And
Exactly.
so, yeah, so I do use pregnenolone, and it's generally a supplement. Sometimes we compound it for patients with low cortisol. I don't generally give it to people with high cortisol. Some people really like it and think it really helps with energy and anxiety and pain. Um, some people it does nothing.
Interesting. I never prescribed that so far. There hasn't
Yeah,
been any.
yeah.
All right. So it was lovely to meet you. And any parting wisdom words you have for us, for viewers, for today about hormones,
Yeah,
about their health?
I mean, I think I have a lot of information on my YouTube channel. I think it's easier to search topics. It's Tara Scott MD. If they search my profile here, they can get to a free download, what you must know about women's hormones. And also, we're kind of revamping an online course aimed at women who want to know more about hormones and what they can do, kind of a lot about what we talked about today. So that's up on online to get, for them to kind of listen in more detail about a lot of things that we talked about today. And yeah, follow me here. Follow me on TikTok, Hormone Guru, and you're putting out a lot of great information as well.
Great to see you. Thanks someday.
Yeah, we'll keep it up. We need people all over. Yes. All right. Thanks for inviting me on
All
the
right.
live.
Thank you. Have a
Okay.
great day. Bye-bye.